So
Yes.
welcome, Colette.
Well, thank you so much, Catherine. I've really enjoyed the senior series that you've put on. I think it was something that is very beneficial for our community and has recognized a lot of the issues that have been neglected for a long time. Well, I will say that besides, which everybody thinks of, end of life, dying, period. And there's a lot more to hospice than that, especially now with the advances in medicine that have occurred and with all of us able to live longer lives. And what we find is that it also affects the hospice service since you're not signing on and dying immediately. Instead, you've come to what we will call the end stage of a disease process, such as, for instance, if you have congestive heart failure. With medications, you've been able to live beyond what was once the normal scope. However, the disease still progresses, and eventually, yes, there will be death. But hospice steps in when you've come to the phase of a disease. There's nothing else that will change the process, there's nothing that will make you better. However, you still have medications that will manage the symptoms. And when we're talking about symptom management, I'm not just talking exclusively about pain, though pain we know is one of the major factors. And I think that's important too, because a lot of times when you mention comfort care, what a lot of people think is, oh, you're talking about the drugs. And the matter is, no, we're talking about the full environment of the person. Pain may be an issue, but it's not an issue with everybody. Sometimes it's just managing the symptoms, having somebody on hand if there a problem arises. Look at the difference. If hospice is in the picture and you spike a fever, all that's needed is to pick up the phone, to call. You'll talk to a nurse, and the nurse will come out and see what's going on, or will start to see what needs to be addressed with the fever, as opposed to going to an emergency room and being sitting there for several hours and maybe nothing's done, or what the difference is that you have been exhausted, you've exposed yourself to a lot of trauma going on, and that is detrimental to your health.
It's just so much work to get ready to go to the doctor's office, load up
Yes.
in the car, get into the building, go through everything, and then reverse it all and get back home. And yes, the patient is then exhausted, and so are the family caregivers.
Right.
And it really is diminishing that time together. And
Yes.
so having a nurse that's on call and able to come right over is terrific. And so hospice can work hand in hand with some of the other services that you're getting at home.
Right. And the important thing, there's several things that are important too, is one, you continue with your primary care physician. Yes, the hospice also has the physician and the medical director and hospice physicians, but they work in tandem. The decisions are made by the family and their primary care physicians. So that is always in place. You're not giving anything up. It also, for a lot of times, people feel, will that restrict? Will that, limit my decisions? And the answer is no, it won't. Naturally, when you sign in for hospice, your feeling is, I want to have what we would call comfort care. I'd like my symptoms managed. I don't want to go back to the hospital. And I want to be able to spend my quality time, as you had said, with my family. So that is the goal. And because we have to look at that at this stage, you need to have more intensive care. And that's what I would put it, as. If you compare taking the medical situation, you would have like on the floor is a medical floor and they're taking care of people and this is what they're doing these treatments and then that's it. When you go to an ICU, you look at the care is more intensive, the person has to be watched more closely and there's a quicker turnaround time to manage the symptoms.
Very good.
And that's what hospice is looking at. Another thing is because you're going on hospice does not mean that you have 6 months to live. What it means is that's a figure that's used.
It means you qualify. Like if you
Yes.
have a diagnosis that
Right.
a doctor says you may only have 6 months to live,
Exactly.
bingo, you qualify for hospice.
And part of the reason we've seen is just simply because you have that intensive level of care. You don't have to run to a doctor's visit. You don't have to wait a week. You can pick up the phone and get the medical help that you need then and there, and that makes a difference. And we do have people that graduate from hospice because their symptoms are managed and they are no longer having declines, and what we call it's a plateau. The medications are working fine, their situation has improved. And I'll say situation has improved. It is not going to say, oh, you've been cured or anything like that. But your symptoms are under control and things are managed. So you no longer meet the criteria. And that's what's important too. It's meeting the criteria. And I can also say, when talking about that 6 months, we've had a lot of times where somebody's come on and said, oh my gosh, they just told me I have a month to live, or in the next 2 weeks, that's going to be it. And 6 months, 7 months out, the person is still with us, and so there's been improvement in their comfort level, and that's what I want, to look at. The comfort level means that your symptoms are managed, you have the medications that you need to go ahead and keep that comfort level and improve the quality of your life. If you have Medicare Part A, you have the hospice benefit.
What if you're 35?
If you're 35 and let's say you're disabled and you've been disabled for 24 full months, which then would qualify you for Medicare, or if you have the condition of chronic renal failure, ALS, you can go ahead and get Medicare earlier.
Okay.
And that hospice benefit is built in automatically in the Part A Medicare. What the hospice, and I'll kind of give you a thumbnail sketch. With hospice, what you receive first and foremost is the benefit starts when you have been signed on. And what you have is that one, your physician may feel that you're in a stage where hospice would be advisable. You yourself as an individual, knowing what's going on with your health, may start talking, or because of a family member, parent, whatever, and what the medical situation is, can start there asking about hospice. And what we'll do is that your physician or the hospital will give a referral to a hospice organization. The hospice organization will then first get medical records together, information from your medical provider. They will call and set up a meeting with you, and at that time come out and describe the benefit and see if that is what you want to do. Now, the hospice benefit starts once you have been formally admitted to hospice, and it takes your primary care physician and the hospice physician to both be in agreement that you do meet the criteria. And that's what we talk about. Technically, the 6 month is a technicality. What it's saying is if absolutely nothing changes, it would be, the prognosis is 6 months or less. However, as we know, nothing is perfect.
Right. No, well,
So,
no one really knows sometimes.
and a lot of times we have been asked, when do you think? And we will tell you, we don't know.
Yeah.
It's your body will take care of that whenever that time comes. One of the things we get, after a family member's passed away is, I wish I would have had you in sooner because of the support that we received. And looking back, it would have been so helpful to have that for our family members, to kind of give you, because one thing I want to be also, which is very important, when we're talking hospice, we're not just the patient. We're talking about the family, the system that supports the patient. So it's all, when we're signing on, yes, we're signing on your mother, your father, whoever. But also we're looking at you too, because you, as the caregivers, are very important and need support. One of the, which I feel is just a fabulous benefit when you have a family member on hospice, you're the caregiver. Well, Medicare allows for 5 days of paid respite so that the caregiver can have a break. Yes, and it's a benefit that Medicare pays for. It pays for 5 days in a long-term care facility, because one of the requirements for the respite is that there is an RN on staff 24/7 at the facility. Whatever you need, that break that you need, sometimes too, somebody needs to have a procedure done, that 5 days gives them a chance. Other times it's just simply to have the break from caregiving. And our caregiver may go ahead and, of course, visit their loved one. However, the fact that they don't have to do all the care for a while gives them that break. And it's not just a one-time only situation where you can only use it once and that's it. You can use it more than once as necessary. And this again shows what we were saying, that it also recognizes that families need a break as well. And it's one of the things I will say many times that we have talked with our families. You need to do self-care, because we feel it's just as important, because you are the primary caregiver and you need to care for yourself. We even offer because we have a volunteer component, and that's one of the things that is part of the Medicare requirement, is that we offer volunteers. And we have volunteers that'll come in and sit 1 hour, 2 hours, so that the caregiver can go ahead and take a break, or go out and get a cup of coffee, or shop, or go to appointments. So anything, again, you're looking at a total support system. Right, and I think that's one of the big dynamics that happen when you become, especially when we're talking about adults, your relationship changes. You're no longer husband and wife. Instead, it's all the focus is on the care, and depending what symptoms there are, especially when you're looking at dementias and Parkinson's, it is very, very demanding, and it affects the relationship between the two individuals. And sometimes getting that break helps the caregiver to be able to reset, some of that relationship. Or, they went out and, like I said, it's a nursing facility, so they go over and they have lunch together. And all of a sudden they're having lunch and talking to each other. instead of, okay, I've got to feed them, I have to
Working
do
on
this, I have to,
prescriptions, right.
yes, because there's a lot of stereotypes about long-term care.
Mm-hmm.
And this is one way to go ahead and address it at no expense to that individual.
That's phenomenal. Plus, I think that there's some conditions that might not do as well being at home unless you were really working on
Yep.
actively
Right.
dying. But if you're really trying to hang in there as long as you can,
Yes.
you might need to be in a skilled care
Yes.
setting.
Right. And it is something that we do sometimes have the talk with our caregivers. Naturally, we will try to be a support, and we honor the wishes if that's what, and anything that we can help. But sometimes it is to a point where if you've got somebody that is just sleeping 2 hours in a 24-hour period or is awake for 48 hours, it is truly physically and emotionally exhausting on an individual.
Yeah.
So, each situation is taken uniquely. We never come in with a prescribed set of you shall this, this, this. What we have is a care plan. A care plan is put together with the care team and the patient and family.
And it's an evolving thing.
Exactly.
It doesn't mean, okay, you signed up for this and this is what you're getting.
Right.
It's a daily, ongoing conversation.
Yes. The best way, and maybe if you're not, a good way to focus on it, is the fact that hospice is an organic service, which means it is, yes, there's the rules of Medicare and what we need to do, which are very important because Medicare is there to make sure that you get what you are supposed to get.
Okay.
That if we say we visited you twice a week, we have proof. Yes, we visited you twice a week.
And you're on call.
And that if we say on-call services, it also covers pharmacy for the terminal condition. So if your terminal condition that you're signed on with is congestive heart failure, then any heart medications, diuretics, and of course pain medications would be covered by your hospice benefit. The only thing it wouldn't cover would be like dietary supplements, vitamins, if you have a secondary condition. For instance, if you're a diabetic. Now, your nurse will be aware and monitor, but we wouldn't pay for the medications and supplies that go with the diabetes.
Okay.
But still, if you look at that, it is quite a savings to the individual
Absolutely.
with those medications.
Well, thank you so much for shedding some light on it.
You bet.
This is a good introduction for hospice, and we appreciate you doing this for us.
Thank you, Catherine, and thank you for letting me share with a wonderful audience.
Thank you. And thank you
Thank
for
you.
watching The Daily Dose.